Welcome to our live webcast, Pains in the Neck and Treatments for Cervical Disorders. Thank you for joining us. My name is Lillian, and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief post-event survey. Please take a moment to complete this survey in order to receive credit for attending and providing feedback of the webinar. We are joined today by our speaker, Dr. George Naseef. At this time, I would like to turn the microphone over to our speaker, Dr. George Naseef, for opening remarks. Doctor, the floor is yours.
Good evening. Hi, I'm George Naseef. I'm one of the attending spine surgeons at Morristown Medical Center. I'm the acting vice chairman, Department of Orthopedics, and I've been asked to speak about pains in the neck and treatment tonight. Thank you for joining us. So no spine talk would be complete without the obligatory Netter slide. The cervical spine is made up of 7 segments, C1, 2, 3, 4, 5, 6, 7. They articulate at the thoracic spine at T1, right in here. Each cervical vertebra has an exiting nerve root below it. The C4-5 disc space has the C5 nerve root. The C6-7 level has the C6-7 level has the 7 nerve root. Something strange happens here at the cervical thoracic junction. Between C7 and T1, there's an extra nerve root, the C8 nerve root. And we'll get back to that a little bit further in the discussion. Subsequently, all subsequential vertebrae, T1, T2, T3, the exiting nerve root corresponds with the vertebral body. This is an axial view here of the vertebral segment. Between each level, there's a disc in the front, and there are 2 facet joints here in the back on each side. The facet joints are joined by the lamina and the spinous process here to form a bony canal around the meninges. This is the dura here. There's spinal fluid in here, and then the spinal cord. Each level has an exiting nerve root to the left and right, and adjacent to the vertebral disc is the vertebral foramen, which houses the vertebral artery. And the vertebral artery goes up and connects and forms the basal artery, which is the posterior circulation to the brain through the circle of Willis. So, as much as we hate to remember it, the brachial plexus comes up over and over and over again from undergraduate to medical school. The upper 2 nerve roots, C5 and C6, form the upper trunk. C7 goes forward as the middle trunk. C8 and T1 form the lower trunk. Each one of these then has a separate branch posteriorly that forms the posterior cord. The lateral cord goes on along the arm, gets the radial aspect to the thumb. The medial cord goes down and forms the ulnar nerve, which innervates the ring and small finger. So today I'm going to talk primarily about subaxial disorders, and when I say subaxial, I mean below C1, C2. The vast majority of this discussion today is going to be centered around acquired disorders. I will show a couple slides of a congenital disorder. I'm going to skip tumors. I will talk about 1 or 2 slides of infection and a couple trauma scenarios. So in terms of when I think about acquired cervical conditions, they range from whiplash to spondylosis. I will talk about whiplash, disc herniations, or abbreviated here HMPs, that can cause radiculopathy, pinched nerve, or can cause stenosis. Spondylosis or osteoarthritis, spinal stenosis, and then instability of spine, whether it's spondylosis or scoliosis. if you look at the picture here on the right-hand side, you'll notice that this is arthritis. This is a small disc herniation on top of a congenitally narrowed canal causing compression of the cord. So I'll start with whiplash and strains. The vast majority of whiplash and strains are traumatic in nature, and they result from MVCs or falls. Patients present typically with pain with range of motion. They'll have muscle spasms and tenderness. No neurologic findings can be present. So if a patient has any deficit whatsoever, it's not a whiplash or strain by definition. Diagnostic studies are not indicated unless a patient has symptoms for more than 6 weeks. When I see substantial whiplash strains like bad motor vehicle collisions, about 10% of those go on to develop chronic pain. So the treatment of whiplash is typically rest, ice, anti-inflammatories, and a young healthy individual, I'll recommend Advil or Aleve. If it's really bad and they're having a lot of spasms, I think Valium works best, but in the current environment, I'm trying to stay away from Valium and going more to medications like Flexeril, 5 milligrams, 1 tablet every 8 hours for spasms. When patients continue to have symptoms, I recommend physical therapy. If they don't respond to physical therapy, you can try alternative treatments such as chiropractic and acupuncture. If they have a focal point of pain, trigger point injections with either Connolly with or without a lidocaine or bupivacaine can really help break up some of those spasms. For the vast majority of cases, whiplash is a self-limited disease. So the next topic I wanted to cover was cervical spondylosis. Cervical spondylosis is a fancy way of saying osteoarthritis of the neck. It's the primary source of neck pain in people over the age of 50 years old. 50% of people, by the time they enter the 5th decade of life, will have findings of cervical arthritis. If you look here, there are 7 segments, as we discussed before. But right where the green arrow is at C5-6, you'll notice that we've lost disc space height. There's spurring there. And C5-6 happens to be the most common level that we see osteoarthritis. C6-7 is the second most common level, followed by C4-5 and then C3-4. So the treatment of spondylosis, 70% of osteoarthritis neck pain responds to ice, anti-inflammatories, physical therapy, activity modification, and occasionally collar. It was actually Bill Dallin, the former chairman here, who I would see in the OR when he had neck pain. He was wearing a collar that turned me on to that one. And I do find that some of my patients who do a short course of a collar have some relief of their neck pain. When those measures don't work anymore, we try to do targeted injections, and I'll refer to interventional pain. And that, once again, can include trigger point injections like I discussed a minute ago, epidural steroid injections, and facet injections. Most of those therapies are based upon what I see on x-rays, CAT scans, and MRIs. If I really believe that the pain is coming from the facet joint, I can refer for a medial branch block. And if the medial branch block works, the interventional pain guys can do a dorsal rhizotomy or a radiofrequency treatment, which you may have heard of. And that can provide relief for axial type neck pain for anywhere from 6 months to 2 years. In general, in patients who just have axial type neck pain without radiculopathy, surgery is a poor option. I've seen plenty of patients have fusions for this, and the vast majority of them end up with limited range of motion and just develop arthritis above. And the limited benefit that they get from the surgery usually isn't long lasting. So the next degenerative or acquired disorder, cervical disc herniation, or HMP. When you herniate a disc, it can herniate off to the side and do nothing. It can herniate into a nerve root where you get a radiculopathy or a pinched nerve. Pinched nerves usually present with burning electrical type pain. It usually follows a dermatome, and sometimes you'll have a focal motor deficit. So a patient will lose the ability to lift their arm over their head or to extend their elbow. If the disc herniation is large enough and presses on the spinal cord, it can cause myelopathy. Myelopathy it will present as upper motor neuron findings, diffuse numbness, and more of a non-focal weakness. The differential diagnosis for radiculopathy is pretty large. I've had plenty of patients referred to me who've had shoulder surgeries when in fact it was a C4-5 disc herniation and vice versa. I've had patients who've come to me for a pinched nerve and it ends up being a subacromial impingement or glenohumeral arthritis. Brachial plexitis or plexopathy or Parsonage-Turner syndrome is a painful condition around the shoulder that often will mimic a radiculopathy. Frozen shoulder along those lines as well. The more common things that we see are peripheral nerve root entrapments, whether it's a cubital tunnel syndrome or carpal tunnel syndrome or a radial nerve palsy like a Saturday night palsy where someone falls asleep on their arm and they have a motor deficit and can't raise up their wrist, and they think they have a surgical emergency and it ends up just being a local palsy in a peripheral nerve. Thoracic outlet syndrome can present and can be either vasculogenic or it can be neurogenic. I've had a ton of patients show up with horrible pain in their arm, and then during the exam I look at their skin and they have a herpes zoster rash, which is extremely painful and just happened to get missed. Lateral epicondylitis is probably one of the biggest ones I've seen. People think they have tennis elbow. They come in with counterforce braces. They've had injections. I've seen surgeries that have failed, and it ends up being a C5-6 or a C6-7 disc herniation with referred pain into the elbow. Pancoast tumor is pretty rare. I believe it's a non-small cell lung cancer that typically is at the apex of the lung that can migrate up, and it catches the inferior portion of the brachial plexus and can present as a C7, C8 radiculopathy. So on physical exam, when I look for lower motor neuron findings or radicular findings, in a more advanced patient, we'll see here there's atrophy of the biceps and atrophy of the brachioradialis. This is would be associated with weakness or flaccid paralysis. There's typically loss or blunting of the reflex. And sometimes as that nerve is trying to recover, there'll be fasciculations. You'll see like little twitches in the muscle occurring. So treatment for radiculopathy in terms of non-surgical, once again, it's the standard rest, ice, anti-inflammatories. You can try a collar for 2 weeks. If the patient is going to respond to these measures, that's usually enough. If they're having a rough time, I'll typically put them on a medral dose pack and enroll them in physical therapy. 75% of radiculopathies are of little to no, either little or mild symptoms. If a patient is really hurting and doesn't have a deficit, we'll sometimes send them for an epidural steroid injection. They're making a ton of these home traction units now that patients seem to like. 8 to 10 pounds for 10 to 15 minutes to get the pressure off the nerve. Some patients have really raved about them, and others absolutely can't stand them. So to me, what are the surgical indications for disc herniation? And this picture here is kind of an extreme example. There's a large disc herniation compressing on the spinal cord. To me, progressive deficit, meaning they're getting progressively worse and having greater weakness or increasing pain. A functional deficit. I describe a functional deficit like a C4-5 disc herniation where a patient can't lift up their shoulder to comb their hair or to brush their teeth. I mentioned intractable pain. Typically, a patient has to fail conservative treatment for about 6 weeks before I'll recommend a surgical intervention. In terms of surgical interventions for just a disc herniation, they include anterior cervical discectomy and fusion, which really is the gold standard. You go in there, take out the entire disc, put a spacer in there and lock it down with a plate and really help alleviate their neck pain and their radiculopathy. Total disc replacements are really catching on now, and their indications are for single-level disease without underlying osteoarthritis and no evidence of cord compression. I think they work really well in the ideal patient, but I'm seeing the indications being expanded at almost an alarming rate. Laminoforaminotomy and discectomies are very rare. The problem is to get from the back of the spine to where the disc herniation is usually involves a vital structure, the spinal cord, being in your way. This is a unique patient. They have this large disc herniation here, but they have a very large spinal canal, and the lamina goes all the way out to here. So if you resect a little piece of bone here, you can actually fish out this disc herniation. And that's what this patient ultimately ended up having and did well, although that's not typical. So I'm going to talk first about anterior cervical discectomy and fusion. It's probably the #1 intervention on the cervical spine from a surgical standpoint. On the floor, the vast majority of these cases are done from a left-sided approach. There was early literature that suggested that the left-sided had a lower incidence of recurrent laryngeal nerve palsy, and that's why so many people started doing them from the left side. More recent literature says that you can do it from the left or the right with the same incidence of recurrent laryngeal nerve palsy. The issue with the recurrent laryngeal nerve is if you stretch it or injure it, you paralyze a vocal cord, and patients will often have difficulty with phonation or hoarseness of voice. So we make a left transverse incision, we raise up platysmal flaps, we find the omohyoid. The omohyoid, if I'm going to go below C5 body, so if I'm going to do a C5-6 or C6-7 disc, I will go medial and inferior to the omohyoid. If I'm going to go above to C4-5, C3-4, I'll go lateral and superior. The vital structure here is the carotid sheath that houses the carotid artery, the vagus nerve, and the internal jugular vein. By getting right through this plane right here, it takes you right down to the longus colli muscles and the front of the spine, and you basically simply retract the esophagus for a safe plane. When an anterior cervical discectomy and fusion is done well, it should look like this. There should be a fusion mass going directly through the center of that vertebral body. There should be bone resected from the back here on the sagittal image, and the plate should be at least 2.5 centimeters from the adjacent superior end plate and 2.5 millimeters, from the adjacent inferior and superior end plates. So I mentioned total disc replacements, and this is the ideal patient. Notice that there is no arthritis in this patient's neck. Every single disc is beautiful. They had an acute disc herniation, had a 1-level total disc replacement, and on flexion extension views, you can see how the spinous processes here close, and when they flex forward, they open back up. Unfortunately, we're seeing a lot of these in the community where the total disc replacement is actually off to the side. This one is off to the right side. Notice the spinous process here. That keel should correlate and be directly over that, and this keel should be over this one. So biomechanically, this is at a disadvantage, and it's actually collapsing here on the left side. And ultimately, this is what happened. The body created bone in front of it, and it went on to fuse. In retrospect, if you look at their indication to do this, I question it. This 4-5 level and 5-6 level are already completely bone on bone. So I'm not sure what they were thinking when they did a disc replacement to try to preserve motion. Next topic that I was going to discuss is cervical stenosis. Cervical stenosis can present as myelopathy, or a sick spinal cord, or myeloradiculopathy, where you get signs of myelopathy and a lower motor neuron lesion, which is a pinched nerve, or neuroforaminal stenosis that just pinches the exiting nerve root and presents as a lower motor neuron finding or just pinched nerve. I like this slide for a couple reasons, because it shows exactly the deforming forces that occur on the spinal cord. So right in here is the spinal cord itself, and a protruding disc or an osteophyte or a condition called ossification of the posterior longitudinal ligament usually will put anterior pressure on the spinal cord. But there's a false joint that occurs with arthritis known as the uncovertebral joint, and as that grows, that presses on the spinal cord from an anterior lateral perspective on both sides. The facet joints, also called the apophyseal joints, will overgrow as a response to the arthritis and press on the spinal cord in a more medial direction centrally. And then as the disc loses its height, the yellow ligament actually will buckle in the back and cause pressure from the back inward. So you can really get deforming forces from circumferentially around the spinal cord that cause stenosis. This is an image here on the right, which actually shows the spinal cord itself, and this is what it looks like when it's been deformed from all those forces I just discussed with you. The definition of cervical stenosis can be an anterior posterior diameter of less than 13 millimeters, or an anterior posterior length divided by the transverse length of less than 0.4. So that ratio is pretty critical for patients that will go on to progress with myelopathy. Cervical stenosis can be magnified by any instability. So if a patient has a tight spinal canal and then they go on to develop instability in the form of a spondylosis or scoliosis, at that segment where there's instability, you can imagine that the stenosis is magnified. And I'll show pictures in subsequent slides. So cervical spondylitic myelopathy, or myelopathy, presents with a wide range of findings. People describe clumsiness in their hands or losing their dexterity, simple things like being able to button a button. We used to ask patients about being able to wind a watch, but nobody winds a watch anymore. Patients will have difficulty with the strength in their legs. They've tripping, they've fallen. They say when they get out of bed in the middle of the night, they have to hold on to walls so that they feel stable. So physical exam findings that are pretty unique or suggestive of myelopathy are pretty much upper motor neuron findings. Babinski sign, you scratch the bottom of the plantar surface of the foot and their big toe goes up. Hyperreflexia, you tap their knee and it shoots out like a rocket. More commonly, we'll see pathologic spread. You hit the knee and their shoulders go up, or you hit the right knee and the left knee goes. Clonus, you jerk the foot and you'll see continuous twitches of the foot. It's usually more sustained. I don't consider clonus to be pathologic unless there's more than 3 beats. Hoffman sign, you flick the middle finger and the actual IP of the thumb flexes. And then Lermite sign is probably the most common, with extreme flexion or extension. Patients that develop either numbness or tingling in their hands or legs, or electrical type sensations. The differential diagnosis of myelopathy includes peripheral neuropathy, most commonly idiopathic or diabetic, MS, motor neuron diseases such as ALS, syringomyelia, cerebral vascular disease, and spinal cord lesions. So this patient here has multiple plaques in their spinal cord, these white areas, but they don't have any evidence of any stenosis. So this patient has a primary cord process and it ended up being MS. So this is another patient who has a focal stenosis, and although the picture isn't great here, right there's some whitening of the cord. So this is early myelopathy. The treatment for cervical stenosis really is close observation. Once they develop myelopathic findings, conservative treatment is relatively limited. Cervical spondylitic myelopathy is usually a slow and insidious process. Somebody I have a question here. It says, what would be the most common presentation to think about cervicogenic post-concussion syndrome? I'm not really sure of the answer to that one. That one's throwing me for a little loop. It's if we're talking about cervicogenic post-concussion, it would probably be hyperreflexia if we're talking about just the spinal cord. The myelopathy, the recent paper by Feelings looked at early versus delayed treatment for cervical spondylotic myelopathy, where this is a multi-center trial. It was prospective, and what they found was surgical treatment led to improved function, improved quality of life outcomes, and disability ratings. What they really found was that earlier disease had better outcomes than later disease. And their suggestion was non-surgical treatment be reserved only for patients who are absolutely considered non-operative candidates. So when we address cervical stenosis, it can be done from the front, it can be done from the back, it can be done front and back. This patient underwent an anterior cervical discectomy infusion, and by putting these 3D printed titanium cages where we do the resection, really allows us to restore the vertebral height. And once you restore the vertebral disc space height, you'll see that the neuroforamen here opens up considerably to take any pressure off that nerve root. But the key here is, look how wide of a bone resection we did here. You can see this actually even tilts up a little bit on both of these to really decompress the spinal cord thoroughly. This is a patient that had stenosis anteriorly and posteriorly. I'll show this film a little later, but they had a process called ossification of the posterior longitudinal ligament. They had a wide resection. This cage here is actually one large case where we resected the part of the C4 body and part of the C5 body and did a long strut with a plate, and then did a laminectomy here from the back and locked it down with screws. Another option for cervical spondylotic myelopathy is a laminoplasty. It's less common. The patient has to have a normal cervical lordosis or normal alignment. If they are kyphotic at all, pitched forward, it's contraindicated. A laminoplasty is done in a way where you green stick one side of the lamina and you cut through the other, and then you sequentially open up a door like this, and you hold it in place with either a plate or with a piece of bone. This is what it looks like intraoperatively. These are little plates here that keep the wedged open lamina, and I think this is a better view. You can put a piece of bone here to hold the lamina open, or a plate. This is what it looks like on a CAT scan. On the left side, you'll see a piece of bone holding the wedge open. On the right-hand side, that's the plate. And this is the advantage. Notice that the patient has normal range of motion after doing the after having the laminoplasty. My issue with this procedure is that I've had several of these go on to fuse despite our best efforts to maintain motion. As another cause of stenosis, I discussed cervical spondylosis. On plain radiographs on healthy individuals, there is a physiologic spondylosis that it's just a normal finding, and it most commonly occurs at the C4-5 level, and it's less than 3 millimeters of translation. What I listed here as pathologic instability is typically when it moves more than 3.5 millimeters and has greater than 11 degrees of angulation. Now, to me, these are the degenerative cervical spondylosis, and then there's traumatic spondylosis, and then there's pathologic spondylosis. This is post-traumatic spondylosis and some criteria. This is a patient who had a C1-2 injury, and this C1-2 injury, you'll look at this soft tissue swelling in front of here, and you'll see a space between C1 and C2. But this was the more important one for this part. I said I was going to try to stay subaxial in nature. This patient has a C4-5 fracture dislocation and has a jumped facets. This patient has 30 degrees of angulation and is translated 50%. So when I talk about traumatic spondylosis, we really break it down into 3 different ones when it comes to dislocation of the facet joints. There can be a unilateral facet joint dislocation. There can be perched facets or bilateral facet dislocation. And I'll show a couple pictures to follow. This is a patient who had a unilateral facet dislocation. So what happened here was, this is the superior articulating facet of the inferior level, and this is the inferior articulating facet of the superior, and this just slid out of place and rotated. And you'll see that typically these patients have about a 25% translation. On the AP view, if you follow the spinous processes up, all of a sudden the ones above disappear. It's because they've rotated to the side, just like this picture up here. And on an MRI, this is what it would look like: a 25% translation, soft tissue edema and injury, and a slight disc bulge, and it causes some compression of the spinal cord itself. It's a picture. This is a CAT scan image of perched facets, and you'll see the inferior articulating facet there is perched on the superior articulating facet on one side, and then on the other side, they're exactly right on top of each other, and that leads to approximately a 25% translation of the cephalad vertebral body on the inferior vertebral body. And this is the worst case scenario. This is bilateral facet joint dislocation. Typically, the facet joints should look like this. The superior articulating facet should lie right in the place underneath the inferior articulating facet. This empty facet sign is typically associated with a greater than a 50% dislocation and a traumatic injury to the spinal cord. So I'm going to take a step back again. I kind of jumped into stenosis and spondylosis, and let's talk more about workup for cervical disorders. And history is critical. I asked a patient about the location of their pain, the type of the pain. Is it sharp? Is it dull? Is it electrical? Is it numbness? Is it tingling? Was there an injury? How long ago was the injury? How significant was the injury? Duration of symptoms. Are we talking 3 months, 6 months, last night? Physical exam, diagnostic studies when indicated. And diagnostic studies can range from X-rays, MRIs, CAT scans, EMGs, bone scans, depending upon where the history, physical exam take me. I used to order a lot of CT myelograms when I was new, probably 1 or 2 a month. I think at this point, if I order a CT myelogram once a year, it's a lot. The imaging of the CT scans have gotten so much better, and the MRIs are fantastic that I really don't find the need to do myelograms anymore. Location of pain, which was the top one there. Typically, if I'm looking for a lower motor neuron entity, you got to know your dermatomes. Know that it's easy to remember if you remember that C7 goes to the middle finger, C6 goes to the index finger, C8 and T1 go to the ring finger and the small finger. And then C5 is more around the shoulder. This diagram does not show T1 going to the small finger, but often people with T1 injuries will have some numbness in their little digit due to the ulnar nerve. This was a study that was done by an interventional pain doctor where they injected a noxious stimuli into the different discs. When they did C2-3, this was the referral pattern. When they did C6 C5-6, this was the referral pattern, and at C6-7, this was a referral pattern with some coming down into the arm. Notice that C5-6 and C6-7 are very similar, with a C6-7 going down a little further. So then the second part of this study is they put that noxious stimuli into the individual facet joints. So the left C3-4, and this is the pattern that they got, which is very similar to C3-4 here. So despite having totally different joints, there's a great deal of overlap by segment based upon where the patient experiences referred pain. So when I do a physical exam, I do range of motion of every joint. I'll do flexion, extension, lateral bending of the neck, rotation. I'll do Tinel's over the cubital tunnel. I'll do a Tinel's and Valen over the median nerve. I do this is a retired grade school principal who's a lot of fun now. He's a rocker. He was willing to take this picture. This is a Sproul's maneuver. I try to laterally rotate them as much as I can before I will put a lateral bend away from me. It's interesting. I'll hold that for a few seconds to see if they develop any numbness or tingling in their hands. Often they won't, and then 15 to 30 seconds later, I'll see them shaking out their hand, and lo and behold, it takes effect. Deep tendon reflexes in the upper extremities, biceps, brachialis, and triceps, and I'll get more into that. Examine the skin. Like I said before, I've seen things like herpes zoster. I once found a tick on someone, and they had Lyme disease. The pulses, I always palpate at least the radial pulse. If I suspect a thoracic outlet syndrome, I'll do an Adams test. I look for lymphadenopathy. I apologize for this slide, but in terms of, I want to talk about motor strength grading. A 5 out of 5 is full range of motion and full strength, equivalent to the other side when you factor out dominance. A 4 out of 5 is full range of motion with moderate resistance against the observer. A 3 out of 5 is full range of motion against gravity, but really not any resistance. A 2 out of 5 is full range of motion once you take away gravity. So the classic example of this is a patient can lift up their arm over their head. That's a 3 if they can barely get it over their head and extend all the way. If you have to wait until you get into a horizontal plane and they can just straighten out their arm and lock it out, that's a 2. A 1 is just any muscle contraction, and a 0 is no muscle contraction whatsoever. So when I do the individual muscle strength testing, I look at, when I'm doing my exam, I'm looking to try to figure out a level. I'm trying to be a detective. So a C4-5 disc herniation will cause a C5, nerve root injury. So I look for deltoid strength and I look for bicep strength. The reflex is the biceps reflex, and the sensation for C5 is usually here on the cephalad portion of the arm and sometimes going down into the upper lateral portion of the arm and occasionally into the thumb. The C6 level gets the biceps, but where I really find weakness is in the wrist extensor. People sometimes have a tenodesis effect where they actually kind of feel like their grip is weaker because they can't keep their wrist up. The reflex for C6 is the brachioradialis, and that's the sensation that comes down along the lateral forearm, the radial forearm, into the thumb and the index finger here. C7 is the triceps. That's tricep strength, and your finger extensors, the triceps reflex, and like I said before, it's the middle finger is the sensory distribution of the C7 nerve root. C8, which comes out at C7T1, if we remember that from earlier in the talk, is the finger abductors and adductors. There is no reflex for C8, and that distribution of sensation is the ring and the small finger and along the ulnar side of the forearm. And T1, which makes up the lower portion of the brachial plexus, is also finger abduction and finger adduction. There is no reflex. The T1 nerve now exits under T1, like I described before, and this is what I just said earlier. This has it at around the elbow, the caudal aspect of the arm, but does not have it going down into the small finger, which I've seen multiple times. And once again, this is just a nice chart showing the disc levels, the nerve it gets, the reflex, the muscle weakness, and the sensation that we'll see. And just to reiterate, there is a C8 nerve root, but only 7 vertebral bodies. I threw this slide in there, and this is actually more of a trauma slide than anything else, and it goes over when to order an X-ray. And there are Canadian C-spine rules, but the Nexus criteria are actually better. You look for a focal. If a patient has a focal neurologic deficit, you're getting an X-ray. If a patient has midline bony tenderness, you're getting an X-ray. If a patient has an altered level of consciousness, you're getting an X-ray. If a patient is intoxicated, you're getting an X-ray. If they had a significant distracting injury, you get an X-ray. My wife's an ER doctor, and she rarely gets X-rays. If she meets these criteria, she's almost always getting a CAT scan. So in the office, when do you order cervical X-rays? And this is the grade school principal again. This is actually a very common position for a patient to show up who's having a horrible cervical radiculopathy. They get relief by bringing their arm up over their head and resting their hand on their head and deviating their head to the contralateral side to try to open up their vertebral foramen. So to me, if a patient's had neck pain for more than 6 weeks without a traumatic injury, I'll get an X-ray. If they have any neurologic deficit, they're getting an X-ray. Red flags, fevers, weight loss, night sweats, bowel bladder dysfunction, they're getting an X-ray. Any underlying connective tissues disorder, rheumatoid arthritis, Ehlers-Danlos syndrome, they're getting an X-ray. If you're considering referring a patient to a specialist, get an AP lateral flexion extension view of the cervical spine. You know, it's old teaching to get obliques. Some spine surgeons still like them. If you want to make things easier, get all 6, and you don't have to worry. And I put this slide in here because sometimes you just know when you need an X-ray. This guy was in horrible pain. Saw him coming in. This is how he initially presented, and I got the X-ray immediately before you hit the room. Normal cervical X-ray. There should be no rotation. The spinous processes should line up perfectly. You can actually see a lot from an AP. You can see that the exiting nerve root on both sides, and this patient has no neuroforaminal stenosis. A real X-ray should go from the cranioccipital level all the way down to see the top of T1. There's the anterior vertebral column line and this spinal laminar line should be intact. There's no evidence of any spondylosis here, and all the vertebral bodies line up. I obtained flexion extension views to see if there's any instability on almost every patient. Right here you'll see as you flex forward, the posterior aspect of the vertebral body relatively stays in line with no transition. There's no translation, sorry. So this is a patient who has hypermobility. She has, you'll notice, a slip here at C4-5 and a slip here at 5-6, which actually increases in magnitude with flexion. I think this 7 millimeters is overestimated. It's probably more around 6, but on MRI she has a capacious canal, and therefore I've been willing to watch this and not stabilize this. She understands that she's probably at an increased risk of a traumatic cord injury if she were to have a bad fall or a car accident, but she's very active and has excellent range of motion right now and is really trying to avoid an operative intervention. This was listed as a normal X-ray. That's a typo. This was an abnormal X-ray. This is actually a high school football player that was sent to me with neck pain. If you look here in the AP view, this is a block vertebra or Klippel-Feil syndrome. And you'll see right here, this is a block vertebra. But what's really neat is he has an anaplastic superior articulating facet joint. So this is small compared to all the other facet joints, and therefore it's hypermobile above. And this young gentleman is at a much higher risk of traumatic injury playing contact sports, and I had to take him out of football. It's a normal MRI of the cervical spine. If you look here, I'm going to start here. There should be plenty of room in front of the spinal cord in terms of spinal fluid, and behind each vertebral body segment should have a nice healthy disc and should have a good alignment with no soft tissue abnormalities posteriorly. Oh, cool. I don't know how that happened. It's a separate arrow. But regardless, this is the axial images going up where you'll see exiting nerve roots on each side. There's a spinal cord with plenty of room. I'm going to try doing that again. There's a spinal cord. You see the vertebral arteries up here and the vertebral body. And there's plenty of room. The facet joints are all healthy posteriorly. This is a CAT scan that looks relatively normal on the sagittal images. This patient has relatively normal disc spaces all around, excellent alignment. But on the sagittal image off to the side here, there is this uncovertebral joint hypertrophy, which is a false joint, and some facet joint hypertrophy here. You'll see the big arrow and the small arrow, and that leads to neuroforaminal stenosis. And this patient presented with a lower motor neuron compression radiculopathy. And you see how much more open this foramen is versus this one. So with the remaining time, I was just going to go over a couple cases. Case number one, this was a 55-year-old woman who presented with burning pain in her left lateral forearm. She had right wrist extension weakness. She had brachioradialis reflex. She had failed conservative treatment. So based upon that, wrist extension weakness, loss of brachioradialis, you're thinking C6. You get the X-ray. You have a C5-6 pathology in mind, and lo and behold, she has a spondylitic level. She's a slight retrolucensis there, and she's bone on bone. We got the MRI. There's a disc bulge here with a small free fragment right here, and you can see it sticking out right there on the sagittal image. It's just impinging on the exiting C5 nerve root. So this is a patient who underwent a C5-6 anterior cervical discectomy infusion. Thorough decompression here posteriorly. My only complaint about this picture that I did, and this is mine, is that this plate is too far cephalad on that vertebral body. It's within 2.5 millimeters, and therefore I put her at an increased risk of degenerative changes here. The only issue, I will tell you that I had to take a lot of bone to get this disc, and if you look here, there really wasn't much room for me to put that plate in any other place. Next patient is a 44-year-old gentleman who had burning pain to the right posterior aspect of the arm with numbness and tingling into the middle finger. His triceps is 3 out of 5. If you remember the chart before, middle finger C7, triceps C7. He's lost his triceps reflex. These were his radiographs, which were a little arthritic, but nothing terrible. Ended up getting an MRI, and you'll see right here at C6-7 there's a disc herniation, but more importantly, it's going out into the foramen. So this neuroforamen here is narrowed compared to the contralateral side. So we had a C7 radiculopathy. And this was the picture I showed earlier, where this is a peak spacer. It's a complex, almost like a plastic that matches bone density with allograft bone. Went on to fuse beautifully in both planes. Next patient is a 42-year-old male who had neck pain, right ulnar numbness, loss of finger abduction and grip strength. So you're thinking C8, T1. These were the radiographs here. And the patient, in fact, had a large disc herniation at C7T1. Here it is here, compressing on the exiting C8 nerve root. And he underwent a anterior-cervical discectomy infusion without consequences and actually did well. He actually is a piano player, and that was the best therapy for him. The 72-year-old man who presented with severe neck pain, headaches, referred pain into his deltoid. He was sent to me by a shoulder surgeon because they initially thought it was his shoulder as well. There was this large disc herniation C3-4, causing compression of the exiting 4 nerve root. He failed conservative treatment, and he underwent a C3-4 anterior-cervical discectomy infusion. I showed this case because look how arthritic he is below here, but there was no reason to do it. It was an isolated focal nerve root injury, and we just treating that was indicated. It's a 44-year-old gentleman who came in dropping items. He had loss of balance. He had lost fine motor strength activities in both arms and had had a previous surgery. This is an interesting case because he had had a previous ACDF. This is a clipple file. The C23 is autofused here, and they had done a C3-4 anterior cervical discectomy infusion. But if you look, this is a bone graft and a plate. They never went back here, and they never got any of the bone that was causing the issue on the spinal cord. And on the axial image here, you'll see all this bone is still remaining. And the only place they got in was this little tiny little window here. So this is more complicated. I need a head and neck surgeon to get me up there to get the plate off. Dr. Most came in. We got up. We took off the old plate. We used a high-speed burr called a Midas. We were able to drill this out. And if you look, a resected bone going up here and all the way down to here. And it's now 100% clean with a new cage and plate. And this patient actually did quite well. There's another really interesting finding here. This patient has, like I said before, he has a block vertebra. And along those lines, you've got to look for other vertebral artery malformations. This is the vertebral artery leaving the vertebral foramen and coming into the vertebral body. So if we were to do our normal ACDF here and cut the bone up and down, I would cut right into that vertebral artery, and this patient would have a traumatic result. Probably would have a significant bleeding if I could even stop it, and maybe even a stroke. And you'll see another picture of that aberrant vertebral artery. Here it is running through the vertebral body of C5, and then it's creating a loop here through that congenitally fused region, and you'll see part of it here. There's a really cool picture of this on a CT angiogram that I was not able to pull up because it was at an outside institution. This is a 53-year-old female who presented with falls, loss of hand dexterity, upgoing Babinski's, brisk reflexes, pathologic spread. I showed this picture post-surgery earlier, but if you look carefully here, there's this white line going posteriorly to the vertebral body. This is ossification of the posterior longitudinal ligament. And on a CAT scan, this is what it looks like. It's actually calcified posterior longitudinal ligament that becomes adherent to the dura around the spinal cord, and it can become quite exuberant, pressing on the spinal cord here. This is because there was so much compression anteriorly, we chose to go anteriorly and posteriorly. This is the patient who had the 2-level corpectomy, and then was taken to the OR and went from the back. For full disclosure, you'll see this soft tissue swelling here. That is a postoperative spinal fluid leak that happened when we took the dura off the spinal cord, and we had to go back and patch this, and eventually it resolved without any issues. I showed this one because this is an interesting case. This is a 60-year-old gentleman, had an ACDF 2 years ago, came in with upper motor neuron findings. And it's just a strange picture for those of you who are used to looking at MRIs of the cervical spine. You jump to this and you think, oh, here's the spinal cord and here's a disc herniation. And that's not the case. This patient had an infection here that was coming up. This is all phlegmon, and this is abscess. So on the axial image, this is all abscess, and this is the spinal cord being pushed anteriorly, and the same thing here. Abscess, pushing the spinal cord, and this is all soft tissue reaction and inflammation. This patient had a laminoforaminotomy and at multiple levels, and the pus was drained. I have a couple more minutes. This is a 66-year-old man who had difficulty swallowing, had a change in voice, had a completely normal exam. His primary symptom for a barium swallow, which showed a mechanical block right here at C23. This is his pre-op CAT scan showing all of this bone. This is the trachea being pushed forward. Took him to the OR, and we resected all of that bone. And this is called Forstier's disease, or DISH. This patient, actually, we made him worse for about 3 to 4 weeks. By 6 months, his phonation was totally normal, and he had no difficulty with dysphagia. It had completely resolved, and he's doing great. I'm going to skip this case. This is a patient. This is a normal C1-2 articulation here and here, and this is what it looks like on a sagittal view. This is a woman who had developed severe headaches, neck pain. She developed a bone-on-bone C1-2 articulation, which was causing greater occipital neuralgia. I sent her to one of the interventional pain docs. They did a steroid injections there. At that one level, completely took the pain away. The reason why I showed that is that somebody was considering operating on her for this arthritic level right there. That was the only one that was left open in her neck. And I think the last case is a gentleman who's a 70-year-old man, fell down a flight of stairs, significant trauma, had severe cervical thoracic pain. He was seen in our ER, was sent home. The CAT scan was read as normal, but he had weakness in his hand, and they still sent him home. They didn't consult anyone from orthopedics or spine or neurosurgery. If you look carefully, all these vertebral bodies look like squares. And then this one here is crunched down just a little bit. It's a little asymmetrical. So he came into the office. He was holding his neck up with his hands. And I looked at this CAT scan with the x-rays I took in the office. And if you look at the space between all of these spinous processes here. All of a sudden, there's a huge gap here. And send him to Morristown, had the ER, and the ER, they got an MRI, and you'll see the disruption of the ligament here. He was taken to the operating room and underwent an operative stabilization and did great. So it was a very subtle finding, and I don't blame anyone for missing it. And I think that the flexion extension x-rays really made all the difference in the office. So in summary, I guess when to refer to a spine surgeon: any neurologic deficit, constant or progressive numbness or tingling, intractable pain, any signs of myelopathy, loss of bowel or bladder function, red flags that I went over with before that correlate with new onset of neck pain. I show this one as a patient that I did a 5-6-6-7 anterior cervical disc. I think it was a 4-5-5-6 anterior cervical discectomy fusion. She was a pedestrian struck by a car. She broke just below her ACDF. I had to take her back to the operating room and stabilize her from the back. She did very well for a few weeks, and then she came in and she couldn't lift her head up at all. And if you look, it's really subtle to see, but right here, this is the C7 vertebral body right here, and this is T1. This is completely collapsed anteriorly and fallen into kyphosis, and she was actively becoming grossly myelopathic. She couldn't stand, she couldn't walk. I had to convince her to come back into the hospital, and I was able to fix her by extending her head and locking her down further with these screws. So no one's perfect, and we do our best to try to help all patients. I want to thank you all for taking the time on a Wednesday night to listen to the webinar, and I hope you learned a few things and can apply them to your practice. So how often would, somebody asked the question, how often would a pathologic reflux sign be an isolated finding that is of significant concern? Is it common for an isolated finding to become, I wasn't aware of this finding, thanks. So clonus, like I said before, if I find clonus and it's 2 to 3 beats, I'm fine with that. When I see sustained clonus, I want to see it. If I see Hoffman's, Hoffman's, for years we used to say that if it was present, it was very sensitive for picking up a myelopathy. The problem is it's not specific, and it's something that I'll use to document in order to get an MRI. But if I see a Hoffman's, it's so common in anyone with any anxiety or type A personality that I don't really hang my hat on it. If I see diffuse hyperreflexia, where it's in the biceps, the brachials, the triceps, the knees, and the ankles, that's less concerning than if the biceps and the brachials are a little bit dull, and then I hit the triceps and it's very brisk and the knees are brisk. Pathologic spread where I hit a knee and the shoulders go up, or a Lermite sign, or a Babinski sign, I find much more concerning.
All right, well, that looks like that's all the time that we have for questions today. Thank you to the audience for participating, and thank you also, Dr. Naseef. On behalf of Morristown Medical Center Orthopedic Surgery, I would like to thank you for your participation in today's event. A post-event survey will appear requesting your feedback. Please take a moment to complete this survey in order to receive credit for attending the webinar. This concludes today's program. Thank you, everyone, and have a great day.